in the code room. Adrenaline is pumping. It's incredibly high stakes, and active chest compressions are underway. Welcome to this explainer. We're skipping the preamble today, mostly because we need to urgently tackle a deeply ingrained clinical habit. It's one that might actually be compromising your patient care.
Right in the middle of the chaos, someone instinctively calls out, "Good pulse with CPR," right? We've all heard it. We all desperately want that reassurance that our resuscitation efforts are actually working. But here's the thing. Hearing that shout provides a really dangerous illusion of efficacy, and we absolutely have to deconstruct that today.
The illusion of efficacy and why manual palpation fails. So the Australian Resuscitation Council, along with the 2025 guidelines, have officially moved away from routine pulse checks. Let's dig into exactly why that is.
50%. Literally a coin toss. In roughly 50% of cases, feeling a palpable femoral pulse during CPR just does not correlate with meaningful perfusion to the heart or the brain. Half the time, that reassuring thumping you feel into your fingers, it means absolutely nothing for the patient's actual neurological outcome.
The anatomy of the error. Let's look at the physiology behind why our fingers are completely deceiving us during a resuscitation.
It comes down to a phenomenon called retrograde venous pulsation. Basically, when you push down on the chest during CPR, you aren't just squeezing arterial blood forward, you're also pushing blood backward through the venous system. So when a clinician feels what they think is a nice, strong carotid or femoral pulse, well, they're frequently just feeling backwards venous flow. It is not the forward arterial perfusion that the patient actually needs to survive.
And this creates a massive behavioral risk. False confidence directly leads to reduced compression quality. Think about it. If you believe the patient is perfusing beautifully because a colleague yelled out that they feel a pulse, you might unintentionally ease up. You might reduce your compression depth or slow your rate, and are doing this exactly when high-quality CPR is needed the absolute most. According to the data, manual pulse checks essentially fail for three primary reasons. First up, low accuracy. We're talking about dangerously high rates of both false positives and false negatives. Second, time delays. These cause completely unnecessary interruptions to CPR. And third, provider inexperience. Look, even highly experienced professionals struggle to accurately palpate a pulse in a chaotic, super high-stress environment like a cardiac arrest.
This data should honestly serve as a massive wake-up call. Manual pulse checks, whether you're checking the carotid or femoral, are inaccurate up to half the time, specifically between 22 and 50% of the time. I mean, think about that for a second. You would never rely on a cardiac monitor that gave you the wrong rhythm reading 50% of the time, right? So why on earth are we relying on our fingers?
The solution: objective data monitoring. It is definitely time to pivot our clinical behavior toward better, evidence-based alternatives.
We really need to contrast these two approaches. On one side, we have manual palpation, which is basically using our fingers to guess at perfusion, and we know how unreliable that is. On the other side, we have the continuous objective truth provided by waveform capnography, which you probably know as ETCO2. This is the preferred gold standard method endorsed by the Australian Resuscitation Council for monitoring CPR quality.
So what exactly are we looking for on that capnographer? Greater than 10 millimeters of mercury, a sustained ETCO2 value above 10, and ideally, you want a number that's trending steadily upwards, is the absolute best indicator that your chest compressions are actually effective. This single metric literally tells you infinitely more about the quality of your CPR than an intermittent pulse check ever could.
You also want to keep your eyes peeled for this specific range, 35 to 40 millimeters of mercury. If you see a sudden, sharp rise into this range, that is one of the earliest and most reliable signs of ROSC, the return of spontaneous circulation. And the best part, it happens right there on the monitor, in real time.
But there is a huge caveat here, and I absolutely need to clarify this. Never, ever stop CPR to check these numbers. Full cycles of high-quality compressions have got to continue uninterrupted. Pulse checks and monitor reviews should only be used very sparingly and only during those brief, strictly scheduled 2-minute rhythm-checked pauses.
Point of care ultrasound, or POCUS. For those of you in units that are actually equipped for it, this is another brilliant alternative. It's significantly faster and far more accurate at detecting true cardiac activity compared to manual palpation. It just gives you a direct, objective visual look at exactly what the heart is doing.
In resuscitation, what we feel with our fingers can sometimes deceive us. What the capnograph shows rarely lies. I really wanted to share this quote straight from our source material today. It perfectly cements the clinical paradigm shift we've been talking about. Your fingers might lie to you, but the data won't.
Which brings us to a final question for you to take back to your team. Is it time to update your unit's resuscitation protocols to eliminate the manual pulse fallacy once and for all? It might be time to rethink those ingrained clinical habits and really champion objective monitoring on your next shift. Thanks for joining me on this explainer. Keep learning and stay focused out there.